So it is a pleasure for us to have Dr. and MD Nachum Soroker with us. Nachum studied medicine at the Hebrew University in Hadassah Medical School, Jerusalem in Israel, and he specialized in physical and rehabilitation medicine at the Lowenstein Rehabilitation Hospital in Ra'anana. He's the head of the Brain Rehabilitation Lab at the Department of Neurological Rehabilitation in the Lowenstein Hospital in Ra'anana. He was the head of the Department of Rehabilitation Medicine in the Faculty of Medicine in Tel Aviv University. He was also the president of the Israel Association of PRM. He was the head of the Department of Neurological Rehabilitation in Lowenstein Hospital. He served as regional vice president of the International Society of Physical and Rehabilitation Medicine and is a member of various ISPRM committees. In 2017, he received from the ISPRM the Sidney Licht Award for outstanding accomplishments in advancing the care of individuals with disabilities and consistent contribution to the advancement of physical and rehabilitation medicine internationally, and for his leadership within the ISPRM. Dr. Soroker co-authored more than 90 original papers dealing mostly with functional impairments encountered in stroke patients. And today he will tell us about his research. So Nachum, welcome to our seminar.
Well, thank you, Sharon. I will talk today about conscious access on the left following right parietal stroke. It's not that I know what conscious access actually means, but I hope with the help of the audience here, probably by the end of the lecture, to understand more about this. Anyway, take care of the pictures that I posted within the different slides. All these have been made by a patient with right parietal damage and unilateral spatial neglect that were hospitalized in our department during the years. I will start with a short introduction about the impact of right parietal damage on spatial attention, on the ability of patients to retrieve information and to report on it when the information comes from the left. And this will be for the benefit of those in the audience that didn't see or didn't treat patients with neglect and were probably familiar about this only from reading in books and like this. Then I'll talk about what happens when stroke affects both the right and the left posterior parietal cortex. And then about what happens when both the right and the left posterior parietal cortex are actually intact, but disconnected because of commissurotomy. The next will be some account on what happens when USN, unilateral spatial neglect to left-sided stimulus, what happened to this stimulus when a second stimulus is presented concomitantly on the right. You will see that this is not always detrimental for the perception on the left. And then this probably will be the most interesting part, will be a way to show the integrity of primary visual processing and explicit evidence for that by manipulation of retrieval strategy during data maintenance in the iconic buffer. And finally, if time permits, I will tell you something about rehabilitation of these patients using non-invasive brain stimulation and EEG biofeedback, and how to select the target location, target cortical location for this kind of intervention. And the take-home, not message, question is, and you can start taking it right from now, who is the agent of awareness and consciousness? And probably, is it necessary at all for an agent to be there? Okay, you know, this is a very philosophically loaded question. So probably what we are going to talk about in this lecture will somehow shed some light on this question. So I'll start with a short intro on unilateral spatial neglect. First, you have to know that this is a very common sequel of stroke. mainly but not exclusively on the right hemisphere, and mainly but not exclusively in cortical regions of the posterior parietal cortex, temporoparietal junction, and superior temporal gyrus area. In fact, for a protracted severe neglect, it is important that the white matter tracts will be disrupted. And this shows the importance of actually a functional network, which is widespread for the, or a disruption of a network for the production of this kind of a problem. Now, what do we have in neglect? The essence is that left-sided stimuli, when I say left, it's not that trivial. What do you mean when you say left? Is it left for the head, or left for the body, or left for the mid-retinal plane, or the left of the object? And in fact, most of these spatial coordinates take place in the production of neglect, or are actually involved in the production of neglect. So what happens that that stimulus, which is on the left, receives inadequate search and less or no attention, and hence it remains outside awareness. This is actually the essence of the way we try to understand this phenomenon. You see the pictures here, you see the photos. This drawing, hand drawings of a human figure have been made by patients in our department, and it's important for me to note that the persons that did these drawings, at the same time, they are not dementic at all. They can talk with you about history, about their profession, about whatever, in a completely coherent manner. Okay, and yet they produce this kind of figures. So we can start with the question of why is the left missing in this face clock, in the butterfly, in the human figure? What happens here? Is it lack of adequate sensory feedback, or is it impaired representation? By impaired representation, I mean that in the mental representation of a clock face, for example, the patient doesn't have 7, 8, 9, 10, and 11. Is it possible? It seems that the first possibility is more likely to be true, but actually the two options seems to take place in neglect, and I'll show you why. But before then, just have a look at this classical way to test neglect. This is a cancellation task coming from the behavioral inattention test, and you can see this patient performance here. This patient, by the way, is a very well-educated person with academic degree, and he had a coronary artery bypass graft operation, and it happened that he sent a small clot, which happened to block the vasculature in the right temporoparietal junction. This patient didn't have any motor problem, any sensory problem. There was no cut of the visual field. He just had neglect. And being very talkative, very coherent verbally, and just having this A4 paper with this stimuli in front of him, he was asked to circle the target stimuli here, which are the small stars. And he, as you can see here, he circled time and again the right side, the right column of stimuli. And for some reason, he didn't bother to move his head or to move his eyes, which he easily can do, and circle the rest of the stimuli. And this was 2 weeks after the cardiac operation, after the onset of the stroke. And you can see that 55 days after the onset of stroke, when he was discharged from our department, despite the treatment, he managed to improve. Yes, you can see that he is much better now. Okay, he is actually circling all the targets. Now, why in the first place, he didn't move his head, he didn't move his eyes to the left. Okay, this is a very big mystery. By the way, neglect is not only interesting, it's also very important, because if you have neglect, if you have right hemisphere damage and neglect, you're going to stay on the mean at least 1.5 months more in the hospital, and you will end up with a much worse functional outcome. So it's a big problem, neglect. It's a big problem. It's not only interesting. Now, failed conscious access is not likely to reflect a simple sensory deficit. Why do I say that? First, because neglect is often multimodal. Those who fail to respond to visual stimuli on the left usually will fail to respond adequately to auditory stimuli as well, and to tactile stimuli as well, and sometimes also to olfactory stimuli, which are located on the left. So it's unlikely to be a problem of passage of information in the visual system that causes visual neglect, okay? And second, because you can see the signs of neglect, this inequality in the processing of information in the right and the left, when there is no perception at all. For example, this is I believe that many of you know this story. This is the story of the study by Eduardo Biziak and Claudio Luzzati in the late 70s. They tested two patients that were in the hospital in Milano after a right parietal stroke and left unilateral spatial neglect. And they asked them to tell what are the stores around the piazza. You see, this is the Cathedral of Milan. Yes, you see it here. And this is the Piazza del Duomo. So in the first place, the patients were required to imagine themselves. You see, they are in the hospital, they are not in place. To imagine themselves standing next to the statue here and looking towards the cathedral facade, yes? And it happened when the patients had to tell about the stores. Then this location is very well known for people who live in Milano. They managed to tell only the stores that, or almost only the stores that are located on the south wing. You see here. And after some time, the Biziak and Luzzati asked them to imagine themselves now in the opposite direction, as if their back is next to the door of the cathedral, okay? And again, to tell what are the stores around the Piazza del Duomo, and from this imagined position, the patient were able to tell only, or almost only, what are the stores on the northern wing. What does it mean? There's no perception here. They can tell what is on the right, they cannot tell what is on the left. So you see that the problem is much, much deeper than just a problem of sensory perception. How do we know that the patient has neglect? So we have the paper and pencil test, and you have seen already cancellation task and figure drawing, and there are copying tasks and line bisection, etc. And there are also visual search tasks that we are using, and I'll show you. For example, this is a test that was devised by Leon DeWell when he did his PhD in our department, and you can see here, I don't know if you see, but here is the target stimulus, and you can see surrounding by distractors. And the next trial, the target stimulus is here, and in the next trial, the target stimulus is here. And you may assume that a patient with right parietal damage and left-sided neglect will be slower to respond to this kind of stimulus compared to this kind of stimulus, because it's more on the left, okay? And also the hit rate will be lower, and probably there will be much more misses on the left, okay? So this is a reaction time visual search pattern, which can be used as feature search or conjunction search, as you wish. And this is how the graphical output comes from for this testing. And you can see red means slow reaction, blue means rapid reaction, okay? And you can see that they are much more quicker to respond to right-sided stimuli than to left-sided stimuli. And many of these patients, they already at this time, when they did this testing, they had their standard paper and pencil tests already normalized. So this is a very sensitive way to test for the inequality of attentional processing on right and left side of space. And you can collapse actually the vertical dimension and leave yourself with the horizontal dimension. And you can see this is much easier for group processing, this kind of viewing. So this was a very short, very short introduction to unilateral spatial neglect. And we can now go on to the second part and see what happens when stroke affects both the right and the left posterior parietal cortices. So you can see here an MRI of patient DP, which was hospitalized some years ago in our department. Yoram Bonnet, he knows him very well because he conducted most of the experimentation. You can see that the patient has both a bilateral temporo-occipital damage and bilateral parieto-occipital damage. This is the usual anatomy of what is called Balint syndrome. In Balint syndrome, you have a clinical triad, which is composed of simultanagnosia, meaning that you can perceive and you can report on one or another stimulus or object in the field of vision, but you don't understand the entire scene, because the visual scene is actually the collection of objects within the visual field. Okay, so this is simultanagnosia. Also, this patient have a very salient difficulty foveating on a visual stimulus or reaching towards a visual stimulus. These are called ocular Apraxian and optic Ataxia. And when Yoram Bonnet looked at the report of this patient while looking continuously to the face of this person is Barack Obama. You know, he was before Trump, and he was actually the boss of the future president, Joe Biden. And the patient had to report whether he sees or not the right and the left eyes. And 60% of the time, there was fading of the vision of the left eye, which means that the perception was unstable, actually, and part of the scene faded, disappeared and appeared, disappeared and appeared. This was more pronounced on the left side, but was existent also on the right side. There are good reasons to believe that working memory is the culpable agent here. I mean, but I'm not going to go into this because there were many other experiments that were conducted by Yoram and others, Shaul Osten and Marina Pavlovska and myself, with this patient. Very interesting. But it shows that actually when you have bilateral PPC damage, there is no total failed conscious access both on the right and on the left. It's a different situation. It's a different situation here. It's a situation where mainly or basically you have simultanagnosia. You don't see the entire perception. You cannot form to yourself, you know, an understanding of what the visual scene is actually, what is there in the visual scene. Now, the third part is the question of both right and left posterior parietal cortex being intact. Yeah, you can see here that this is the situation. You see, whenever I move the cursor, it tends to move to another slide. But you see here the intraparietal sulcus. So this means that this is the inferior parietal lobule, and here more dorsally is the superior parietal lobule. And you can see the posterior parietal cortex, actually the entire brain doesn't show in MRI any structural damage. And probably you also have seen by now Oh, you see, this is how it happens. You see that the genu of the corpus callosum here and here, and actually the entire trunk of the corpus callosum is severed. This was done by a doctor, okay, a neurosurgeon. And the reason for doing that, this operation is called forebrain commissurotomy. This is a total forebrain commissurotomy, which includes not only the corpus callosum, but also the anterior commissure and the posterior commissure and the abennular commissure. And this was done to separate the two parts of the forebrain in order to prevent generalization of epilepsy, which started from medial temporal regions on the left or on the right, okay? This was to save the patient from frequent falls. This patient didn't respond well to medications, to anti-epileptic medication, and it was necessary to do this kind of operation. And this gave us an opportunity to test how each hemisphere in isolation performs kind of neglect tests like the line bisection. In line bisection, what you see in line bisection is that usually patients err to the right. For example, in this line, you see in this line, this is the subjective midpoint, which shows actually that the patient was able to see until here. And all this part, the leftmost part of the line, didn't get conscious access, okay? Here you see, oh, it's always happening. Here you see the, no, I cannot do it with the cursor here. You see on the left here, the performance of a group of patients on line bisection. As you can see, the deviation, yes, the deviation is greater. The error is greater with longer lines. Okay, so the rightmost line is 180 millimeters and the leftmost line is 18 millimeters. And the longer the line, the higher the deviation, the greater the deviation. And you see in T1 is the production of the mean performance of these patients when they arrive to rehabilitation, and T2 is when they left rehabilitation. You can see that although they got the rehabilitation treatment for 2 or 3 months, line bisection errors are quite persistent, much more than, by the way, than cancellation tasks. So how did our patient GH, how did he do this this kind of task, the line bisection? So what you see here in the green is an error to the right, and this is the production of the right hand. Right hand means left hemisphere in isolation. There's only processing in the left hemisphere that guides the performance of the right hand. And then in blue, you see the performance of the left hand. And the left hand is guided by the right hemisphere, the isolated right hemisphere, intact but isolated right hemisphere. And you can see that the error goes to the left. So actually the right hand is showing us, the right hand or the left hemisphere is showing us a left neglect pattern. And the left hand or the isolated right hemisphere is showing us a right neglect pattern. This is very peculiar because usually we think about the left hemisphere as acting as an interfering with processing in the damaged right hemisphere of neglect patients. But here we see that actually there is a very big importance to the cooperation between the hemispheres. They have to be connected actually, such that this bias by the single hemisphere will be balanced and a patient will be able to see coherently and to respond coherently to the stimuli in the entire field.
Nachum,
yes?
May I ask a question about the previous slide?
You want to ask now or you want to ask in the end?
Fine, I'll ask in the end, that's okay.
Fine. This will be easier for me because I'm not sure I'll be able to finish what I wanted to say. That. Okay, sure. But you can see that it's not only a problem of line bisection. You see the right hand, by the way, was the only one by which we could get any response to the question to, to draw a clock face or a human figure or a flower. There's no way that he would be able to get this kind of an instruction and perform this task with the left hand, because his right hemisphere cannot understand this kind of a verbal command. So you see that the isolated left hemisphere actually draws a clock face and a human figure and a flower exactly like a patient with neglect, with right hemisphere damage. This is very strange, I think. Okay, so as I said, it's not only the case that the two hemispheres interfere one with the processing of the other, it's also there is a kind of cooperation that is needed. Now we get to the question of what happens to a left-sided stimulus in the situation of a neglect patient when he received concomitantly a stimulus on the right. This is also something that Yoram Bonnet in the audience knows very well because he was part of this study. And you can see actually that what happens on the left depends on what happens concomitantly on the right. If the two stimuli are close one to each other, if they are collinear, if they are isocontrast, it is likely for the neglect or extinction, in this case, of the left-sided stimulus be lower. However, if they are not collinear, for example, this kind of orientation of the two stimuli, the right-sided stimulus will extinguish the left-sided stimulus, or if the contrast of the right-sided stimulus will be much higher than that of the left, the extinction will be much stronger. So actually, the chances for conscious access of left-sided stimuli depends not only on the properties of the left-sided stimulus, but also on what happens at the same time on the right side of the visual field. Here we get to the issue of why actually the patients fail to report on a salient visual stimulus that occurs on the left. Why is that? Is it because they cannot transmit the visual information from the retina to the visual cortex? Or because of something that has to happen after the visual processing or the primary visual processing? Now, look at this. You see here, this is a normalized lesion data from one of our patients. And this is a typical case for the anatomy of neglect. You see that this is a right middle cerebral artery infarction with a very prominent damage to the temporal lobe, to the parietal lobe, to the frontal lobe. However, the medial structure, including the thalamus and including the lateral geniculate body in the thalamus, as well as its afferents coming from the optic tract and its efferent in the optic radiation, as well as the primary visual cortex in the middle part of the occipital lobe, all this is completely normal, intact, which means that the information from the left reaches the primary visual cortex in a correct manner. There is something that happens afterwards that impairs the conscious access of left-sided stimuli. And here we aimed, okay, here you see a group of patients, and what I've said before, you can see it in more patients. And if you look carefully at each of these patients, each line is a different patient, you can see that in some patients there might be a problem if the infarct is very deep, goes very deeply. It may impair part of the optic radiation of the Meyer's loop, causing some kind of quadrantanopsia or like this. Okay, but in most patients, actually, the visual pathways are entirely intact in most of the patients. Okay, so our question was, why actually the information is blocked from reaching conscious awareness? If the visual pathways are intact, there must be something else. So we focused on a stage which is called the maintenance of the information in the iconic buffer. The iconic buffer actually is a hypothetic store where information is held for a very short period of time. And there is a way to access the information at this stage. And in this, we followed the protocol that was devised some 60 years ago, I believe, or more than 50 years ago by George Sperling, which is called the partial report paradigm. When George Sperling tested human subjects with this kind of arrays, as you see here on the left, bottom left, it was usually the case that subjects, normal subjects, were able to, after some delay, they were able to report that they have seen 3 or 4 of the letters. This could be, for example, ARVX, for example, or ADYL. Not more than that. The exposure time here is some less than 50 milliseconds usually. And George Sperling asked, what is the block here? Is it the block for the acquisition of the information or for the production of the response? So after variable queuing delay, he gave a second cue. And the cue in this case was a tone, high tone or low tone. With a high tone, the subject is indicated to report only what he has seen in the upper row. With a low tone, he is asked to report only what he has seen in the lower row. And it happens that with a high tone, the subjects, they say ARHL consistently. The same 4, but here the entire demand is accomplished. Okay, the demand is to report only the upper row. With a low tone, the patient will say DYVX. What does it mean? It means that in the time of the queuing, this is post-presentation queuing, in the time of queuing, the patient had, or the system, the neural system, holded the entire information. Okay? In the whole report situation, he would say the same 4, but this was part of the upper row, part of the lower row. So we wanted to see if the block, the conscious access block in neglect, respond to this kind of partial report paradigm. Okay, you see that the maintenance of information, okay, this trick actually holds or gives an advantage if you perform it within the time of maintenance in the iconic store, which is the 500 milliseconds. Actually, 500 milliseconds is too much, but better to do it 100 milliseconds after the stimulus presentation. And here's what we did. We checked 17 right parietal patients. All had stroke in right MCA territory. 7 of them were in the chronic stage and 10 in the subacute stage. And all of them showed clear left-sided neglect, both in paper and pencil tasks, like this one in the line and bisection and cancellation task, and also in the reaction time visual search task. Here is the situation. You see that you start with fixation in the middle of the screen. Then you can have a cue. In this case, it will be a pre-cue. And then you have the stimulus. If you have the pre-cue indicating report on the left, the patient has to say 2. Okay? And but the parameters were target exposure 33 milliseconds, cue exposure 100 milliseconds, and the stimulus onset asynchrony was 100 milliseconds. The second paradigm was position post-cueing, post-presentation cueing. You start with fixation in the middle of the screen. You then have the stimulation. You see the pair of digits in this case. And then after a delay, yes, a 100 millisecond delay, comes the post-presentation cueing, which tells you to report not the entire field, but only that which was, as the arrow indicates, that is on the left in this case. Here is what happened. This is the performance on the left. We are interested actually in the performance on the left. The right is more or less okay. The performance on the left in the whole report is no more than 40% correct. When you give a pre-cue, it's a bit higher, but not significantly higher. And with post-presentation cueing, it is much higher on the left. Just consider that during the cue, during presentation of the cue, the arrow, actually the stimulation is no longer in the field of vision. So the cue can work on what is stored in the iconic store. After this success in, or the advantage that was seen on the left side processing by partial report, we ask ourselves whether it's the condition of extinction does not have to be only 1 on the right and 1 on the left. It can be 2 on the right and 2 on the left, or even 3 on the right and 3 on the left, or 4 on the right and 4 on the left. What will happen then? Look here. Oh, it's okay. On the left side, look at the upper panel. On the left, you see the whole report. Whole report is very poor. This is the report, the upper panel is the report on left-sided stimuli, yes? And you can see that with the pre-cue, it's a bit better, but with the post-cue, especially at 100 millisecond stimulus onset asynchrony, it is very much higher. See what an advantage give the post-presentation cueing here. In fact, just look here. You see in the upper panel here, if you collapse all the information from all these experiments, you can see that in 100 millisecond partial report condition, there is no neglect at all. Conscious axis is exactly the same, left and right. Okay, so we know that the patient anatomically has the structural basis for processing the input, the visual input from the left in a proper manner anatomically. And we also know that this hypothetical construct of or buffer, yes, of the iconic memory also holds the information properly. And if it's skewed to report the left part of the stored information in the iconic memory, the patient actually does not show the failure of left-sided stimuli to reach conscious awareness. So the remaining question is why and how the information is afterwards blocked. Okay, but this is actually what is called the Holy Grail, yes, question about neglect. Now, finally, I want to tell you a bit about what can be done when the posterior parietal cortex is destroyed, or I would say the inferior part of the posterior parietal cortex. Usually neglect patients have damage in the ventral part of the posterior parietal cortex or in the ventral parts of the frontal cortex. This is actually the location of what is called the ventral attention network. The ventral attention network, if you believe Maurizio Corbetta and his team, is actually a system, an attentional system that deals more with the bottom-up allocation of attention. When you need to respond or you need to allocate your attention to something happening, not voluntarily, not happening in the environment, actually. And this is the system that is damaged in neglect patient. However, we have another attention system, which is more dorsally located, also frontoparietal, including anteriorly the frontal eye field and posteriorly the areas around the intraparietal sulcus and the superior parietal lobule. And this is the dorsal attention network, and because it is supplied largely by the anterior cerebral artery, it is intact in most of the patients. And it was shown by fMRI studies in the group of Maurizio Corbetta in St. Louis that the neural plasticity that occurs in this dorsal attention network is actually the key to the recovery from neglect, such that parts of this dorsal attention network start working in a manner that enables better interaction between the right and the left, this importance of cooperation that we talked about before, and also taking part of what was previously processed by the more ventral system. In general, you need to know that recovery, true recovery, either motor or cognitive, whatever, is usually based on neural plasticity, adaptive plasticity of the cortical regions that are perilesional, around or close to the damaged area. And we could show the importance of this superior parietal lobule, the dorsal attention network. We could show it also in a mathematical analysis of the impact of lesions to different locations to the severity of neglect on line bisection. This work was published years ago in Human Brain Mapping with the help of people from the mathematical department in Tel Aviv University. It's a method that it is called multi-perturbation Shapley analysis, and it is derived from game theory, and it allows an assessment of the relative contribution of different parts of the network to the processing of given processing. Okay. And we could show that the superior parietal lobule, although it is usually damaged in very low frequency, on the mean, only less than 9% of the voxels within this area are damaged in neglect patients. It has a very high contribution, secondary only to the supramarginal gyrus, in the production of neglect phenomena. So this is a good perilesional target for non-invasive brain stimulation. You know, this application of either electrical stimulation in the form of transcranial direct current stimulation or magnetic stimulation in the form of repetitive transcranial magnetic stimulation, yes, high frequency, to increase the likelihood of formation of strong synaptic connection after the training and obtaining of good recovery. Sharon, if you could
Yeah, sorry
mute.
about that. I muted them.
Okay. And there are indications in the literature, for example, this study that was published in Brain by Sperringham, France, showing in this group of neglect patients that electrical stimulation, direct current transcranial stimulation can help neglect patients if you apply the excitatory electrode, the anode on the right, or even if you apply the inhibitory electrode, the cathode on the left PPC. So following that, we decided to try to recruit the arousal not from above or not from the outside, but from the inside, because the reticular formation of this patient is actually intact, yes? It only we need to draw from it enough arousal for this critical area of the superior parietal lobule. So we use the EEG biofeedback, and the patient in his EEG biofeedback training, they are seated, with the EEG monitoring all the time, they are seated in front of a screen, as you see here on the upper right part of the screen. And by thinking whatever they want, they need to try to elevate this ball upwards. So they start thinking this or that, and sometimes the ball goes up and sometimes it goes down. And this is the interface that enables the feedback actually. And we test them with Starry Night, our Starry Night here on the bottom left, before and after the training. And the training takes place for 30 minutes every day, 5 days a week, Sunday to Thursday, then the next week again, Sunday to Thursday. Quite easy. And here's our first patient. You can see before and after neurofeedback, the very big improvement that he has made on the left and also on the right. You can see here a group of patients. And you can see in green the reaction time on the right side stimuli, and the blue is the reaction time for left-sided stimuli. You can see the difference between left and right, attesting that this patient had left-sided neglect, all of them. And here is the improvement after 10 sessions of EEG biofeedback, where the electrode P4, which is situated over the superior parietal lobule, served as for the feedback. You see, you can see that the overall or the average improvement with these 10 sessions was 23%. I mean, reduction of the reaction time to left-sided stimuli, which is quite nice. So this gives us hope that with this kind of neuroplasticity modulation tactics, like with the magnet, with the electrical stimulation, or with EEG biofeedback, we can probably improve the outcome of neglect patients and obtain better results, because, as I said before, neglect is a very severe problem for patients. Here you see one patient. Of course, this is the best patient that we had. And you can see before and after, before and after, before and after on each of the 10 days, the improvement in reaction time to left-sided stimuli. And you can see the reorganization or the network that is forming around the lesion area. And this actually is the story that I wanted to convey to you today. And I need to thank many persons that participated in all these studies, The late Professor Michael Mislobodsky was my mentor, and ייבדלו לחיים ארוכים, I don't know how to say it in English. All the rest that you see here, some of them are in the audience, I think. I need to thank all of them, because for me as a clinician, it was a very big benefit to work with people that are doing basic research and learn from them. Now, if you want to download for yourself part of this PDF, there are about 38 papers in PDF format that can be downloaded if you click on this. I understand that this all this will remain for offline inspection for those who wishes. From my account in ResearchGate, you can actually download all these papers on neglect and spatial cognition issues. So I wish to thank you for your spatial attention. I don't know, whatever. Okay.
Thank you very much, Nachum. I would like to ask everybody to unmute themselves, and let's give Nachum a big applaud for a very interesting and inspiring talk. And I would like to open, everybody can ask questions. Feel free to ask. I also have my own questions. Okay, I'll start. With the training, I want to ask about the training that you just showed at the end. Was the actual biofeedback on central stimuli, or did it vary? Was it on the right or on the left? I mean, the ball looks to me like it's in the center of the
center.
So it was always on the center?
Yes.
And yet they improved also on both sides?
Yes.
So how do you...
There is place for improving actually our interface, the interface with the computer. This was the first time that we did it, and we just picked up, one interface and did it. But then there are many interfaces which are more interesting, I think, with Pac-Mans and with cars and with whatever,
My question is about the fact that this is a central. I mean, it looks to me like some sort of on their midline, and I wonder, or in the center, and it's not on the left, let's say. I mean, or it doesn't move to the left. I don't know, something of that sort. So
I believe you are correct. If we could be more intelligent picking the the interface, and there are actually interfaces. I'm not aware of other people doing neglect research with EEG biofeedback. This is mostly used with, subject with ADHD or things like that. But yeah, surely we could actually, as you know, Maurizio Corbetta, he showed that the improvement in neglect depends on the restoration of coherence between right and left PPC areas. So we could actually give feedback, a positive feedback for an increment in coherence. And as you said, use left-sided stimulation or more left-sided stimulation, or stimulation that goes from right to left, or like this, and get a better response. This was just kind of a pilot study that we did.
Can I ask a question?
Sure. Hi, Rafi.
Hi. I want to ask a general question on models of conscious awareness, and specifically on visual awareness. And usually these neglect effects are cited as evidence that you need a parietal lobe in order to have visual awareness. But I liked your bilateral lesion, what you call balint, and I think it argues against this concept, because you show a case where both parietal lobe is essentially destroyed, and nevertheless, the patient is able to see. It's true that they are unable to perceive the entire scene and all that, but they are able to have a visual experience. So I want you to comment on the theoretical implications of such findings.
people used to accuse the left posterior parietal cortex for much of the trouble that is occurring with right-sided damage. So the idea is that you don't get conscious access for left-sided stimuli, salient stimuli on the left, not only because you have lost parietal neurons on the right, but because the remaining right hemisphere is suppressed by the left hemisphere. Now, with the bilateral damage, you remove this suppression. And that is why you don't have a clear, coherent perception, which is stable both on the right and both on the left. But you see from time to time, or you don't see from time to time here and there. It's a matter of maintenance of information in working memory, probably, that is becoming the more salient problem. There is no preferred location for the loss of the conscious axis. So this may be the idea. Of course, we don't know if the left and the right parietal cortices do the same here. Most probably they do not do the same.
No, but the bottom line is that you don't need the parietal lobe in order to see. Just, I think that's a very straightforward, simple interpretation of this bilateral damage.
I don't think so. I wouldn't say so clear-cut manner.
Well, I removed the bilateral lobe by the parietal lobes, and I still see. So how else can
you haven't removed, not completely at least.
Yeah, of
not
course,
completely, but I see. I mean, I have some visual
There is some damage. You don't know exactly to what extent.
Ah, okay. So it's not the full extent. That's the argument? Or?
That's one possible argument, at least.
Possible, yeah. But the question is what the data is showing.
But you cannot take, I think, Balint patients as evidence for destruction of the entire posterior parietal cortex, right and left. And this is not the case also in the MRI that I've shown you. Part of the posterior parietal cortex on the right and on the left is destroyed. Part is destroyed, not the entire.
So you think the islands are what maintains the visual perception?
Probably.
Okay.
Probably.
That's a possible answer.
By the way, we have clear evidence. Our Sperling experiment with the iconic memory, the activation of the left side of the information maintained in iconic memory, is an explicit demonstration that left-sided stimuli reach the system. I wouldn't say who in the system, who is the agent here, but they reach the system and they are maintained. They don't not only past, the retina, the optic tract, the lateral geniculate nucleus, the optic radiation, the primary visual cortex, they reach farther and are maintained now in the iconic memory in a complete form. Okay? But there are also indirect evidences for this. For example, recently we published several papers with Shaul Hochstein that show, that the analysis of statistical processes, the statistical processing of a visual scene, for example, what is the average size of all the stimuli in the visual scene, or what is the average contrast in all the stimuli of the visual scene. So you'll take a patient with neglect and you can calculate exactly and see that left-sided stimuli for which the patient is unable to report exactly what the stimuli were, they still are taken into account when the statistics of the entire scene is computed by the patient. There's a clear demonstration for this. Or for example, we had a study with Avishai Hennig and Sharon Zamir about a Stroop effect. You need to say what is the color of the ink in the middle, but then you put a discordant color on the left, which the patient cannot tell what is the color, but still you have an effect. The Stroop effect become longer. The reaction time becomes longer. So there are many indirect evidences, or lines of evidence that left-sided stimuli are perceived. But we say that the person, yes, Nachum Soroker, he doesn't see it, but it is perceived. Yes, it is perceived. It can act on the decision of the person, on the motor output of the patient, behavioral output of the patient.
Okay, thanks.
So Nachum, do you think it's an issue of awareness? So it is perceived, but it's not entering awareness in a way. As for example, I mean, DF, that's completely different story, but still, I mean, she could use visual information in a way, I would say perceive it, but she was not able to report it, but she was able to use it for motor actions. So would you say that it is perceived without awareness to some extent? I mean, would that be similar?
I don't know, you are a vision scientist. Tell me what is perception? I would like them to understand. I understand passage of information, transmission of, currents, electrical currents from the retina to V1. This is something that can be measured, I understand. But when you say perception or seeing, what do you mean? I mean, what is the agent that it sees? Or, for example, if you do the line bisection, I've shown you line bisection, yes? If you ask a patient to bisect a line of, let's say, 20 centimeters, he will usually err to the right. And you can measure the amount of error and give a measure or a quantitative measure of the severity of neglect on line bisection. Now, if you take a road, a metal rod, suppose this is a metal rod of 20 centimeters, and you ask the patient to pick it from the middle, just so that it will not be like this, but it will like this, yes? This was done by Elizabeth a lot of us. They are likely to pick it from the middle, exactly from the middle. And the idea is, you had one of, okay, the idea is that the more dorsal parietal pathways, that is vision for action, might be okay, might be intact, whereas vision for consciousness is impaired. The more ventral part of the parietal cortex is impaired. So that probably the patient utilizes, here's the question, who is the agent? Yes, the one who picks in the middle, the metal rod, or the one who is asked to draw the middle.
To bisect the line.
To bisect the line, yes. Who is the agent here? Because one of them shows neglect and one of them doesn't show neglect, and they both have the same name. And they look alike.
Okay, we have to discuss this further outside of this forum. I will write to you about that. That's fascinating.
So I have a separate question. It goes back to what Sharon, you had asked at the outset. I was wondering for the training that you had done, with the Star Unite stimulus, you're more or less forcing people to use something like goal-directed attention. And Nachum, you distinguished in your talk between sort of two systems, right? Let's say a bottom-up and a top-down network. And I wonder whether you might consider using, let's say, a more realistic stimulus so that the things that people are meant to attend to are driven more, say, by a bottom-up than a top-down kind of instruction for what they should be looking at.
I think the top-down and bottom-up are their value is the value of dichotomy, like capitalism and socialism, or like they say. It cannot be only top-down or only bottom-up. It might be mostly bottom-up. For example, if you are walking in the street and you bump on some obstacle, and you need to draw your attention to this unexpected perturbation, this is a bottom-up allocation of attention. But if you're running in the street towards a goal, which is very important. For example, you're running to save someone who is drawing in the river in front of you. You will pay much less attention to this obstacle on the road than if you're just walking.
Mm-hmm.
Now, in this starry night, sure, you are asked to watch the computer screen, and you have a specific task. Press with the index finger of the right hand, with the index finger of the right hand, press whenever you see the stimulus appearing, okay? But then the appearance of the stimulus is completely haphazard. It's random. It appears once here and one there, and there's nothing ordered there. There's a random appearance, and you have to actually react to the unexpected appearance. It is said that the problem, the attentional problem, the problem of allocating attention to left-sided stimuli in neglect is evidenced basically in bottom-up situations, much more than in top-down.
Mm-hmm.
And this is actually because you can instruct the patient, which is something very important in the treatment, by the way.
Yeah.
You can instruct the patient, look carefully to the left, you are missing things that are important on the left. So it happens that after a period of rehabilitation with such an instruction, which means actually top-down compensation for bottom-up failure,
Mm-hmm.
the patient starts to show disadvantage on the right in this kind of testing, like the starry night. He will show longer reaction times to right-sided stimuli. This happens in the recovery period, and afterwards it normalizes about, let's say, half a year or 1 year later, it may normalize. So that there is an interplay, I think, between top-down and bottom-up, and this is a very sensitive testing, this starry night.
Mm-hmm. Yeah, I would very much agree with the top-down, bottom-up interplay. I'm thinking kind of on the lines of the really old Yantis and Janides work, where they showed with the kind of calculator face numbers, like matchstick numbers, that appearing a number, let's say there's nothing on the screen, and then like the number 5 appears. Whereas you could take a figure 8, disappear a couple of the matchsticks that make it up, and then that number 5 is much less salient because it didn't have like an onset transient applied to it. It was elsewhere that there was an onset transient. And I just feel like there might be ways of, let's say, biasing the system to use or to rely more or less on the bottom-up information that's supplied in the stimulus, but by using tricks like that. But yes, it's definitely a point well taken that these two systems aren't sort of operating in isolation. And thank you. It's really interesting. I just wonder whether you had any plans to try some of that in any, let's say, future biofeedback studies, or is that not?
Well, honestly, the next 1 or 2 years are going to be devoted mainly to rehabilitation of the upper limb in my in my laboratory. So I'm not sure.
Okay. Thanks again.
Are there any more questions?
I wanted to ask a question, if possible, from the non-professional side. I suffer from I know Nachum and some of the people here, but I'm not in the field of research in this area. But I suffer from neglect, from a right parietal brain injury, and I was tested for like 10 years ago. I was tested in Birmingham in a brain research center, and they put me in a situation in which I was on the screen. I was presented with stimuli, on both on the left and on the right side, and I was supposed to say whether they were two stimuli and they were the same, H or O or whatever. And I remember after the end of the first week, I began, in the beginning I was seeing only I was responding only to the stimuli on the right side. At the end of the first week, I was tested every day for about 9 hours. I was a very good guinea pig for them. And in the end of the first week, I started to respond to stimuli on the left side. I have what was called in the beginning hemianopsia, and now, of course, it's left lateral neglect, unilateral neglect, and they started to respond on the left side in quite a normal way to stimuli on the left. Then I came back after 2 months, and after 1 or 2 days, I began to respond again normally, or what's so-called normally. And I wonder if you can respond on that. I mean, I was tested there. I don't know what the background, you know, the theoretical background or explanation for this phenomenon, if you can reflect on it.
This was, to those who are not geologists in the audience, this is Professor Yoram Meshet, and he, and he had a very severe right parietal brain damage from a shrapnel, if I recall well, in the Yom Kippur War, which didn't prevent him from doing a completely normal life and very high achievements in his profession. And it's very interesting. I think you're really a very good guinea pig subject. I mean, for those who want to learn from a very intelligent person about this syndrome. I would, I don't know if they published, the people in Birmingham, if they published, you know, the studies that they have done with you, I would be able to better understand what exactly happened. But certainly if you train a patient time and again, as actually I've seen you here, I've shown you here, where is it? Here, for example, in this patient, you can see that reaction time during 10 session days improves from, let's say, starting from 950 reaction time on the left in the first day to some, what is it, 600, I think, 650. So this is a reduction of 300 milliseconds in reaction time to left-sided stimuli in just in 10 sessions. So I'm not very much surprised that if you did their 9 hours of visual scans, I mean testing with visual stimulation, you improved so well. Okay. But,
okay. Thank you.
Thank you very much again, Nachum, for a very interesting and inspiring talk. And so again, many thanks. I'm welcoming you to join me. Okay, at least some of you are muted, but we can see the hand claps.
okay.
Next week we will have, it's December 29th. Some of you or more of you will be on holiday, end of year vacation, Christmas vacation. So Professor Chris Tyler will be with us at 5 p.m. Note the unusual time. I'd like to thank you again, Nachum, and I'd like to wish you all happy holidays, Merry Christmas to the ones who are celebrating, and happy 2021. May it be a better year for all of us, and may we still benefit from the things that we can from that the corona has taught us, but have a better year. So thank you.
Yeah.
תודה רבה.